Back to the next session. It's a pleasure to invite the next speaker, Dr. Malavika, our beloved HOD at KMC Manipal. Dr. Malavika has 16 years of clinical experience in anesthesia and specializes in pediatric anesthesia. She has multiple publications in national and international journals and has authored 2 book chapters. She will be speaking on the topic newer anticoagulants and antiplatelets and neuraxial anesthesia.
A very good afternoon, everyone. I hope you are all refreshed following the tea break. So now let's delve into another important topic, that is the newer anticoagulants, antiplatelets and its role in neuraxial anesthesia. So let me begin with a case scenario. There is an 80-year-old male who is posted for total hip replacement following severe osteoarthritis of the hip. The following are the comorbidities: COPD, hypertension, old history of stroke with recent atrial fibrillation. The patient is on the following medications: ramipril, metoprolol and rivaroxaban. So, I am sure all of you will be able to identify the anticoagulant medication here. Yes? Yeah, that is rivaroxaban. So, now when you know that this patient is on the anticoagulant, there are so many questions which rise in our minds. Whether you can stop this anticoagulant and plan for a regional anesthesia. In case you want to give a regional anesthesia, when do you need to stop this drug, and what is the risk of thromboembolism versus that of bleeding? Whether would you like to employ a bridge therapy for this patient? So, let us try to answer these questions with this topic. To begin with the introduction, managing patients on antithrombotic therapy is a challenging task for the perioperative physicians. The interruption in the therapy increases the risk of bleeding, whereas the interruption in the therapy increases the risk of thromboembolism, whereas the non-interruption in the therapy increases the risk of bleeding. With the development of protocols for the prevention of thromboembolism and development of the potent antithrombotic drugs, there have been raised concerns of neuraxial bleeding and development of epidural hematomas. The incidence of the vertebral canal hematoma is about 1 in 7.75 lakhs following spinal, and 1 in 26,400 epidurals and 1 in 17,800 combined spinal epidural, according to a study published in Finland. Now, we should be very cautious when we administer neuraxial anesthesia to patients who are on antithrombotic therapy, so as to avoid the devastating neurological complication of spinal epidural hematomas, which can leave the patient with a permanent neurological deficit if left untreated. Moving on to the objectives of today's lecture, I will be briefly delving into the pharmacology of the newer antiplatelets and the anticoagulants, learn how to monitor the effects of antithrombotic therapy, go into the emergency reversal of anticoagulation in case of acute bleeding states, and also we will go through the ASRA 2018 newest guidelines regarding the timing of discontinuation and resumption of the antithrombotic drugs following the administration of neuraxial anesthesia. We will also touch upon the clinical features and management of spinal epidural hematoma. The common indications for patients on antithrombotic drugs are as follows: patients who present with acute coronary syndrome, stroke, peripheral vascular disease, atrial fibrillation, patients to be treated either therapeutically or prophylactically for the venous thromboembolism, as well as patients on the prosthetic heart valves. Now, the antithrombotic drugs are broadly divided into 2 categories: the antiplatelets and the anticoagulants. Antiplatelets are those drugs which reduce the initial clot formation, and anticoagulants are the drugs which slow down the process of the stable clot formation. Coming to the antiplatelet drugs are classified based on their mechanism of action into COX inhibitors, which includes aspirin, NSAIDs, the P2Y12 inhibitors, ticlopidine, clopidogrel, prasugrel, ticagrelor and cangrelor, the glycoprotein 2B3A inhibitors, abziximab, eptafibetide and tirofiban, and the phosphodiesterase inhibitors dipyridamole and silastazole. This slide shows the mechanism of action of these antiplatelet drugs. The most commonly used drugs, which are the cyclooxygenase inhibitors, basically inhibit the formation of cyclooxygenase and the production of thromboxane A2, thereby interfere with the initial platelet aggregation. Aspirin is one such drug, however, it does not require discontinuation in patients who are subjected for neuraxial block, although it irreversibly blocks the platelet production for 7 days. The platelet production is a continuous process, about 10 to 15% of it is formed every day. Therefore, aspirin as a drug alone need not be stopped prior to neuraxial blocks. Now coming to other drugs, that is the P2Y12 inhibitor, which acts by ADP receptor blockade, and this also prevents the platelet aggregation and formation of the platelet plug. They include clopidogrel, ticagrelor as mentioned earlier. The glycoprotein 2B3A inhibitors act by inhibiting the final common pathway of platelet aggregation, and the phosphodiesterase inhibitors dipyridamole and silastazole. Dipyridamole is primarily used for the prophylactic prevention of stroke, and silastazole as a vasodilator in the treatment of peripheral vascular diseases. So, these act by the vasodilating properties. Now, we will go into the comparison of the most commonly used drugs, that is the P2Y12 inhibitors. As you are all aware, clopidogrel forms one of the components of the dual antiplatelet therapy in patients with cardiovascular disorders, and the clopidogrel is an irreversible inhibitor. It brings about 60% of the inhibition of the platelets. It brings 60% inhibition of the platelets, and when it is administered as a maintenance dose, it acts in 3 to 5 days, whereas when administered as a loading dose of 600 milligram, it acts in a duration of about 6 hours and acts for a duration of about 5 to 7 days. Prasugrel is also an irreversible inhibitor, but it brings about 80% inhibition of platelets, and it acts within a period of 2 to 4 hours. When compared to clopidogrel, it is faster, and the duration of action is also longer for a period of 7 to 10 days. Ticagrelor is a reversible inhibitor, and that brings about inhibition of about 80 to 90% of the platelets, and onset of action is within 2 hours, and duration of action compared to clopidogrel is shorter for a period of 5 days. Cangrelor is an IV direct reversible inhibitor and blocks about 95 to 100% of the platelets. Please note its onset of action is within 2 minutes, half-life is around 3.5 minutes, and offset of action is 90 minutes. So, Cangrelor is currently not used in India, and it is basically used for the PCI procedures for the prevention of stent thrombosis and for the revascularization of patients who come for repeat PCI procedures. Now, are there any tests which monitor the effect of antiplatelets? Although we routinely do not monitor them, there are tests which monitor the effect of the antiplatelet therapy, and they are as follows. They include the platelet function analyzer 200, the vasodilator stimulated phosphoprotein assay, verify now assay, multiplatelet test, and platelet mapping component of the thromboelastogram. The last one, that is the platelet mapping component of the thromboelastogram, is the one which is used by the anesthesiologists more commonly. Now, moving on to the perioperative management of patients who are on antiplatelet therapy. Now, a patient who has undergone a PCI procedure and is on dual antiplatelet therapy, the elective surgeries are postponed for a duration of 6 weeks following bare metallic stents and 6 months in patients who have undergone a drug-eluting stent. But in situations like time-sensitive surgeries like major cancer surgeries, this period can be de-escalated to around 1 to 3 days. In such situations, the bridging therapy should be considered. So, in patients who are at high risk of cardiac events, clopidogrel may be interrupted for 5 days prior to surgery and 7 days prior to surgery if they are at low risk of cardiac events. The antiplatelets can be resumed 6 hours post-operatively in those at risk of high cardiac events and 24 hours post-operatively in those at risk of low cardiac events, as per the recommendations of Ducatis et al. Now, we move on to the directly acting oral anticoagulant drugs. These have revolutionized the practice of anticoagulant therapy and have almost replaced the traditional anticoagulant warfarin. Now, why are these drugs turning out to be superior alternatives? The reason for this is as follows. The directly acting oral anticoagulants, first of all, are administered, as the name says, through the oral route. They are much more safer. They have very few drug interaction as well as dietary interactions. They have a very predictable pharmacokinetic and dynamic profile, and most importantly, they do not require repeated laboratory monitoring just as we do with warfarin. So, for all these reasons, since the last decade, you can see there are a number of drugs which have emerged, and the latest of which is betrixaban, which has come out in 2017 after the FDA approval. Moving on to the pharmacology, I will try to condense this slide. So, if you see, dabigatran is a direct thrombin inhibitor. Rest of them, rivaroxaban, apixaban, edoxaban and betrixaban, are selective 10A inhibitors which act on the final common pathway of coagulation. And the oral bioavailability of dabigatran is a prodrug. It is about 6.5%. It needs to get activated by the esterases in the liver, and the onset of action of all these directly acting oral anticoagulants is within about 2 to 4 hours, and the duration of action of these drugs is within about half-life is about 12 to 24 hours. Therefore, they have a shorter duration of action compared to the traditionally acting warfarin, which takes a longer time for its onset as well as offset of action. Dabigatran, please note, is heavily dependent on the kidneys for its clearance. So also is rivaroxaban, whereas betrixaban is mainly eliminated through the GI route. There are tests for monitoring the anticoagulant therapy, and they are as follows. Warfarin, we need an INR of less than 1.5 for performing the neuraxial blocks. Heparin is monitored by APTT and ACT. The low molecular weight heparin and fondaparinux is monitored with the anti-10A levels. Dabigatran is monitored with the APTT, activated partial thromboplastin time, thrombin time and Ikarin clot. Rivaroxaban is monitored with the anti-10A SA and PT. Apixaban with anti-10A SA and dilute PT. So, if you see, the directly acting oral anticoagulants are monitored by the anti-10A SA. Now, when the patients are on this directly acting oral anticoagulant therapy, it is important to monitor the liver function as well as the renal function, as they are dependent on these organs for their metabolism and elimination. Is it necessary to bridge patients who are on directly acting oral anticoagulant therapy? Now, routinely this is not indicated because of their rapid onset and offset of action, and once the treatment is reinitiated, the restoration of effect is also rapid. Hence, routinely the bridging is not necessary. However, in patients who are at high thromboembolic risk, it may be indicated. Moving back to our case scenario. So, in this patient, how do we go about? So, considering his age and in view of the procedure, in view of the comorbidities that he has, the ideal option would be to go for a regional anesthesia, expecting the looking into the advantages of the centroneuraxial block. But at the same time, we need to weigh certain factors to administer neuraxial anesthesia. What is the patient specific bleeding risk? What is the procedural risk? What is the risk of thromboembolism? And should this anticoagulant be continued or discontinued? Now, the patient specific bleeding risk in patients of atrial fibrillation who are on anticoagulant therapy is assessed by a scoring system called as HAS-BLED, and based on this score, a score of more than 3 indicates a high risk of bleeding. Now, coming to the procedural risk, this patient falls into the high risk category for thromboembolism, and this patient has got atrial fibrillation in which a CHAD score is assessed. A CHAD score of more than 4 indicates a higher risk of thromboembolism in patients of atrial fibrillation. Besides, his creatinine clearance is also quite low. So, in view of all this, it is better to defer rivaroxaban and switch him on to a bridging therapy, possibly with subcutaneous low molecular weight heparin, and stop this about 24 hours prior and then administer spinal anesthesia. This drug can be restarted after about 6 to 24 hours following the procedure once the perioperative course is uneventful. So, the reversal of anticoagulation. So, in situations where then there is acute bleeding in patients who have been treated on anticoagulant therapy, the reversal is done with the following means. Stop the anticoagulant. In case of hemodynamic instability, start the patient on supportive measures such as fluids and blood products. Activated charcoal may be administered to reduce the by absorption, and this has to be administered within a period of 3 hours. Consider dialysis to hasten the elimination in patients on dabigatran. Consider directly acting oral anticoagulant reversal agent idarucizumab for dabigatran and andexanet for rivaroxaban, apixaban, the 10A inhibitors. Consider the prothrombin complex concentrates, they are available as 3 and 4 factors. So, for INR of more than 2, it is indicated at about 25 international units per kg, for 4 to 6 35 international units per kg, and for more than 6 50 international units per kg. Consider administration of tranexamic acid. So, moving on to the ASRA guidelines. So, here we will be discussing the summary of it. So, ideally it is said that at least 5 half-life intervals should elapse for the 97% of the drug to get eliminated, with only 3.125% remaining in the circulation. Now, ASRA guidelines are quite conservative guidelines when compared to the European and Scandinavian guidelines. The European and Scandinavian guidelines recommend 2 half-life intervals, and another important factor is when do you resume the anticoagulant therapy. So, this is based on the study by Rosencher et al., wherein he said that 8 hours is the time for the clot to get stabilized. So, 8 hours minus the time taken for the peak effect of the drug is the time for resumption of the anticoagulant therapy following the neuraxial block. That means, if the patient is on rivaroxaban, 8 hours minus the time taken to develop its peak effect, that is 2 hours, it would be 6 hours. So, 6 hours following the neuraxial block, this redosing of rivaroxaban can be done. Now, dabigatran, as I told earlier, is dependent mainly on the kidney for its elimination. So, in a patient with normal creatinine clearance of more than 80 ml per minute, it can be stopped for a period of 72 hours, and in patients less than having a creatinine clearance of less than 30 ml per minute, it is better to avoid the neuraxial block. Similarly, for rivaroxaban, apixaban, edoxaban, as per the ASRA guidelines, it is 72 hours and the drug can be resumed 6 hours later following the neuraxial block. Argatroban and bivalirudin are direct thrombin inhibitors which are administered through the IV route, and neuraxial block should be avoided in those patients. Now, patients who are on parenteral 10A inhibitor, that is fondaparinux, the discontinuation time period is about 36 to 42 hours and it can be resumed 6 hours postoperatively. So, regarding the interruption of the antiplatelet therapy, it has already been discussed. So, I will quickly go into it. So, for clopidogrel we consider about 5 to 7 days, and ticagrelor is also 5 to 7 days. As per the Scandinavian and European guidelines, it is for a shorter period, and for ticagrelor it is 3 days and for clopidogrel it is 5 days. Now, in any case, in case you need to interrupt the antiplatelet therapy much earlier and proceed with the neuraxial block, you should always consider performing a platelet function test, that is the platelet mapping portion of the thromboelastogram, before administration of neuraxial block. Now, with glycoprotein 2B3A inhibitors, abciximab, eptafibitide, which are basically used for the PCI procedures, the period of interruption for abciximab is 24 to 48 hours and eptafibitide and tirofiban is 4 to 8 hours. There is no specific guidance given regarding the resumption of these drugs. Dipyridamole is stopped for 24 hours and silastazole is stopped for 48 hours. Resumption may be done by 6 hours. Coming to the next component, that is the spinal epidural hematoma. As I told you, it is a devastating neurological complication following the neuraxial blocks in patients who are on anticoagulant therapy. What are the clinical features in this condition? The patient can present with sudden severe onset of intense back pain with or without a radicular component. The pain gets aggravated in conditions wherein the intraspinal pressure is increased, like coughing and sneezing. There is a return of sensory motor deficit following an apparent resolution. The diagnostic test for this is MRI, and the definitive treatment may be undertaken by going for a decompressive laminectomy within 8 hours to obtain a favorable neurological profile. So, what are the risk factors for this? Elderly patients, females, those with spine abnormalities, those with congenital or acquired coagulopathies, thrombocytopenia, and procedure related like going in for multiple attempts, traumatic taps, and insertion of epidural carries more higher risk compared to single shot spinal or single shot epidural. Drug related like patients who are on antiplatelet or anticoagulation therapy or treated with fibrinolytics. So, these are the conditions wherein you need to be very vigilant and monitor them post operatively. So, coming to a quick recap of this, as you can see here on the left hand side we have the vitamin K antagonist warfarin, and then the directly acting oral anticoagulants and the antiplatelets. If you can see, the directly acting oral anticoagulants need to be stopped about 3 days prior to the surgery as per the ASRA guidelines, but as per the other guidelines from the societies of Scandinavian as well as those of European guidelines, they say a 1 or 2 day interval of interruption. That is, in case of low risk of events of thromboembolism, you can stop for 1 day and resume after 1 day. If the patient is a higher risk candidate, stop for 2 days, resume after 2 days. So, they have simplified this. There is something called as a pause trial which is going on by Ducatis, and therefore, if you go as per the ASRA guidelines, it is 3 days. So, to avoid confusion, you go by the ASRA guidelines and state that it is 3 days of interruption and resume directly acting oral anticoagulants after 6 hours. So, you need to have a checklist in place when you are doing a pre-anesthetic evaluation. Note the exact date and timing of stopping the anticoagulation therapy, perform a detailed spine examination and look for any spine abnormalities, discuss and inform the relatives regarding the risk of central neuraxial blockade versus general anesthesia. Also, you need to adopt a multidisciplinary approach in case you are planning for bridging the patients on anticoagulation therapy. An expert anesthesiologist should perform the procedure so as to avoid multiple punctures and traumatic tap in high risk categories. Use of USG or C-arm to mark the entry point for neuraxial blocks, and use of lower concentration of local anesthetic drugs so as to identify the motor blockade and for the ease of neurological monitoring. Therefore, to conclude, the regular updation of knowledge and current anticoagulant protocols is extremely essential. The clinical management in patients who are receiving the antithrombotic therapy, you need to understand the pharmacokinetic properties. There is no cookbook approach, and it should be tailor made, weighing the risk versus benefit of regional anesthesia against a definitive risk of spinal epidural hematoma. So, with this I conclude. These are my references. Thank you.
Thank you, Dr. Malavika. An extremely well presented lecture. Thanks a lot.
Thank you, sir.
Just a question. Suppose you have a patient with stroke. They are on antiplatelets as well as anticoagulants. So, if they are on both the drugs, what should be the approach? And if they come for an incidental surgery?
So, is it an emergency procedure or elective procedure?
No, it's an incidental surgery, an elective surgery. So, if they are both on antiplatelets as well as anticoagulants, so what should be our approach in these kind of conditions?
So, in patients who are on both antiplatelets as well as anticoagulants, there is a high chance of development of neuraxial bleeding. So again, in such situations, you need to weigh the risk versus benefit. Like if it's an elderly patient who is likely to go on a ventilatory support for a long time, it depends, you can, and the procedure is elective, you can interrupt the therapy and then post the patient once he is off these drugs. So that would be the first option. If they are not able to stop the anticoagulant therapy for long, then it would be ideal to go for a bridging therapy for such patients and then repeat the coagulation tests and then proceed. So it is dependent on the consultant which path he can choose.
Have our very own dynamic alumnus, Dr. Eshwar MV, for an interactive session on the topic Approach to Diabetic Ketoacidosis. He is also the best outgoing student of the 2014 batch of our department at KMC Manipal. Dr. Eshwar is currently working as an assistant professor at AIIMS Mangalagiri. Over to you, sir.
Very good afternoon, respected faculty, dear delegates, and my dear Manipal Anesthesia family and the organizing team of APGAP 2024. It gives me a great pleasure, and it's truly nostalgic to have come to Manipal and to be receiving all the love as usual. And I congratulate the organizing team. They have done a commendable job. My dear friends, Dr. Shweta and Dr. Suajit and their team have done a commendable job under the guidance of Anita ma'am and Malavika ma'am. And I profusely thank you from the bottom of the heart for providing me this platform to share my views on this very important acute medical emergency, which I will be trying to interact with the delegates in the next 25 minutes. So this topic is very relevant because diabetes is never going to get cured. You are always going to encounter these patients in your clinical setup, whether they in the ICUs or whether they come for your elective procedure or emergency procedure. This is unending. And what is more important is, and what is more alarming is, every year there is an increase of about 3 to 4% in the prevalence of patients getting diagnosed with type 1 diabetes mellitus. And we all know that these patients are more susceptible to this acute medical emergency. So I bring to you a clinical vignette. Suppose, say for example, you are a postgraduate and you have this case. Don't worry, you can make mistakes here. A 55-year-old diabetic has been posted for an emergency debridement for non-healing ulcers in both the feet. At 11 p.m. in the night, your surgical colleague finds out that you are his best friend, and he tells them, no, please, the patient is going to lose his limb and I want to debride this patient. The patient, over the phone call, you come to know that he is a known diabetic for the last 15 years and he was on oral hypoglycemics, but after admission, they have started him on some broad spectrum antibiotics. They have put him on subcutaneous insulin and they have posted him for debridement. You are not sure about any other investigations. History-wise, you find out that your surgical colleague tells you over the phone, no comorbid illness, nothing, NPO is adequate, and you tell him, okay, you shift, let me have a look at him outside the OR. On examination, you find that the patient is drowsy, GCS is 11/15, heart rate is 118 per minute, and BP is around 90/50, respiratory rate of 22, room air saturation 97%. What would you do? Do you want any more information from me? Mike. Any more information regarding the history? We have not moved on to the investigations as such. From the history.
Duration of diabetes.
Duration, 15 years. 15 years was on OHS medications. That's a good thing. Any other thing relevant to with respect to the vitals? Any other thing you want to know? No, I just gave an arbitrary value, sir. That's why I didn't put the E, V, M, N component. Right. I never expected this question. So, say for example, now you have a look at this patient. Can you play the video for me?
So it's important because when you talk about traumatic brain injury,
yes, sir,
the motor component is most important.
Yes, sir.
But here you will probably look at the
eye-opening and the verbal response more than the motor. Yes, absolutely. So what sir stated here is, if the patient had a traumatic brain injury, the M component of GCS, motor component, becomes more important. Otherwise, the eye-opening and verbal response becomes important. So you have a look at this patient. Can you play the video for me? So you find him, this guy is breathing this way. Is it normal or abnormal?
Abnormal.
Abnormal, right. So what is happening here? There is slight increase in the rate and also increase in the depth of respiration, right. So with this, what investigations would you want? We'll catch hold of someone else. She's really nervous. What investigations would you want?
So given the history, we can ask for urine ketones.
We can ask or you will ask?
We can ask for urine ketones.
Directly urine ketones. Okay.
ABG.
ABG, directly ABG. Okay, fine. So CBC gives you a hemoglobin of 9, total leukocyte count is elevated. That indicates that probably he has some underlying infection. And platelets are 1,25,000 per millimeter cube. Okay, you ask for RFT, you have a creatinine value of 1.2, slightly elevated. Sodium levels have dropped down, potassium is marginally on the lower limit. Chloride levels seem normal. LFT coagulation profile, as asked by you, seem to be normal. Yes, everybody wanted GRBS. You do a spot GRBS outside the OR and you find that the GRBS is 350 milligram per deciliter. Poor glycemic control over the last 3 months. HbA1c is 9.8%. Urine analysis gives you sugars 2 plus. Ketone bodies are present. Good, you diagnose something. And CRP is elevated. I do not know the surgical surgery from the Department of Surgery. They have done a CRP. Someone has even ordered for a serum osmolarity without knowing what is the, why. What was the necessity of doing it. Anyways, now again you wanted ABG, right? So the mic to her. So what is this? Is the pH normal or abnormal?
No, sir.
What is it? Acidosis. Okay, what is it? Metabolic, respiratory?
It is.
What is the direction in which the pH and PCO2 are moving? In the same direction or opposite? So what does that mean? Metabolic, right. So pH and PCO2 are moving in the same direction. So obviously the primary component is metabolic. I am not going to ask you to tell me whether it is adequately compensated by using the Winter's formula. What I want you to calculate is the anion gap. What is the anion gap here? I have given you the values. Somebody else. Roughly. You don't need to be very specific.
The cations minus anions.
I have given you. I just want you to put the values.
130 plus 3.5.
Yeah, you have to calculate and tell me. Anybody who's quick with fingers because I'm losing time. 2.5.
20.
20.
23.5.
Yes, 20. Right, 20 is, what is the normal anion gap?
8 to 12.
Okay, fine. 12 plus or minus 4. But yes, so this patient has an anion gap of 20. Is it high, low, normal? High. So this patient has high anion gap metabolic acidosis, right? All of us are interested in knowing imaging. You have chest X-ray, ECG, echo here, and everything seems to be grossly normal, right? So with this, you come to a conclusion that yes, probably he has diabetic ketoacidosis. What is the triad of diabetic ketoacidosis? Mike's on the other side. We are targeting the one limb. What is the triad? Already we have given you the clues.
Acidosis.
Okay.
Hyperkalemia.
Hyperkalemia, diabetic.
Glycemia.
Hyperglycemia, okay.
And
Keto. What does keto mean?
Serum
Good,
ketosis.
very good. So yes, the patient is having all the three components. He is a diabetic, he has ketonemia, and also he has acidosis. Right. So the diagnostic criteria is given by 3 bodies. One is the American Diabetic Association, and then you have the UK Council, and also you have the American Association of Clinical Endocrinology. What I want you to follow in gross is that you focus on the plasma glucose level, and I think it is easy to stick to milligram per deciliter. Don't forget about millimoles. If you want to convert millimoles to milligrams for blood glucose, you multiply it by 18. So plasma glucose levels more than 250 milligram per deciliter with a pH of under 7.3 and bicarbonate of under 15 millimoles per liter and positive for urine ketones. All the councils recommend doing blood ketones, but unfortunately none of the hospitals have a facility to measure the blood ketones, many centers, so they rely on urine ketones. Right. Once you have done this, now you have confirmed the diagnosis of diabetic ketoacidosis. Now what are the statements which are true about diabetic ketoacidosis among the following? Does it have absolute insulin deficiency?
Not necessarily.
Not necessarily, okay. Is it more common in patients with type 2 or type 1?
Type 1
Okay,
is
it has a mortality rate of 5%.
more
Than 5%, DK? Not sure, okay. It is more common in elderly?
No, sir.
No,
Type 1
okay.
is-
Can it occur in patients with normal glycemic states, euglycemia?
It can happen.
Not bad at all, excellent. It is a state of absolute insulin deficiency. Okay, and it can occur in patients with euglycemic states. That is what is called, and these are seen in patients who are consuming this new class of anti-diabetic medication, which is sodium glucose co-transport 2 inhibitors, and or the patient has reduced hepatic glycogen stores, as in the case of decreased caloric intake, alcohol abuse, pregnancy and chronic liver disease, and this is what is called as EDKA, euglycemic diabetic ketoacidosis. So diabetic ketoacidosis is of two types. You have HDKA and EDKA, which is hyperglycemic diabetic ketoacidosis and euglycemic diabetic ketoacidosis. Why is this not hyperglycemic hyperosmolar coma? This is a very important acute medical emergency in patients with diabetes as well. Almost presents the same way. Normal? Yeah, very good. So if you look into the diagnostic criteria for HHS, the plasma glucose levels is almost 3 times that of 2 to 3 times that of type 1 diabetic ketoacidosis. In DKA, the plasma glucose is 250 milligram per deciliter. This is in millimoles. So you take this number as 30 and multiply it by 18, it gives you a value of 540 milligram per deciliter. So patients with HHS have a blood sugars of almost more than 500 to 600 milligram per deciliter. pH, if you look, it mostly they don't have acidosis, and acidosis in patients with HHS is mainly because of an underlying dehydration or acute kidney injury. Urine ketones are negative in patients with HHS, and plasma osmolality is more than 320. In DKA, the plasma osmolality does not increase as that much of HHS. Can you tell me the formula for plasma osmolality? Just going through the basics. So it is 2 into serum sodium plus glucose divided by 18 plus blood urea nitrogen by 2.8. So what are the precipitating causes? So precipitating causes are very important to be identified whenever you have a patient with DKA or HHS, because the precipitating cause is the one which causes these two acute medical emergencies, and luckily the precipitating causes are common for both DKA and HHS. They are inadequate insulin therapy, as in this patient. Maybe the subcutaneous insulin which was administered to him in the ward was inadequately dosed. He has an underlying infection. Of course, he is not pregnant, but yes, pregnancy can precipitate DKA and HHS. Certain metabolic stressors, new onset diabetes, and certain drugs like SGLT2 inhibitors, glucocorticoids and diuretics, all these can precipitate DKA and hyperglycemic hyperosmolar syndrome. Easy to remember is infection, infarction, infant on board, indiscretion and insulin deficiency. What you need to remember is infarction. Even an underlying myocardial infarction or a cerebrovascular accident like stroke can precipitate DKA or HHS. So it is very important to rule out an underlying stroke and a myocardial infarction in patients with this medical emergency. So what do I do? Do I optimize this patient, 55-year-old, or do I post him for surgery? Do I optimize or do I post? 55-year-old, bilateral diabetic foot, drowsy, he has abnormal breathing, high anion gap metabolic acidosis, tachycardia, hypotension. Do I take him up?
As it's an emergency procedure.
Sorry, as it's an emergency procedure. So he is a good friend of his surgical colleague, so he wants to take up for procedures. He will be called for future cases as well. Anybody else? He wants to optimize. Okay, what is the reason? Why do you want to optimize?
Because surgical stress will increase the
surgical stress can increase. Even more importantly,
infection.
Infection. Okay. So the Royal College of Surgeons has come up with these guidelines as to how to take a call whether do you want to optimize a patient with acute DKA or do you want to take this patient up for OT. So if a patient with DKA comes to your OT with an ongoing injury or an ongoing hemorrhage which is limb or life threatening, take the patient up immediately and simultaneously start your resuscitation measures. But if your patient is in septic shock, you have at least 3 hours to optimize the patient. So shift the patient to either critical care or start the management outside your OT or in a place where you have adequate monitoring, optimize for 3 hours and then take the patient up. Patient with severe sepsis and organ dysfunction, you have 6 hours with you to optimize these patients. Patients without organ dysfunction, you have 18 hours, and patients who have no sepsis, least emergency, shift them to critical care unit, provide the necessary care that is to be given to them and then take them up for the surgery. So with this background, which category does our patient fall into? He has severe sepsis with organ dysfunction, reduced GCS, AKI, hypotension and high metabolic anion gap acidosis. So my plan would be to optimize him. I will shift him to the critical care unit and I will try to optimize this patient, take about 6 hours, explain to my surgical colleague and the patient's relatives that controlling or taking over this medical emergency is very important rather than operating him at this particular point of time. So the summary is manage each patient individually. Resuscitation is the key to success until and unless the patient requires an immediate surgery. Now coming to the brief pathogenesis of DKA and HHS, I will be stressing more on DKA because the topic is DKA. What everybody needs to remember is there are two important things happens in DKA. Absolute insulin deficiency and elevated counter-regulatory hormone. Now coming first to absolute insulin deficiency, insulin all of us know is an anabolic hormone, agreed? Right. So when there is insulin deficiency, there is going to be a state of catabolism. So what is going to happen? Carbohydrates are going to break, you are going to have glycogenolysis, you are going to have gluconeogenesis. Proteins again are going to undergo proteolysis, so they are going to give you substrates of gluconeogenesis. Similarly, there is going to occur extensive lipolysis. Now, why does this extensive lipolysis occur? The extensive lipolysis is mainly because of this hormone sensitive lipase. So what happens is normally there is no hormone sensitive lipase. In insulin deficient states, usually insulin is the hormone which keeps a check on hormone sensitive lipase. So when insulin is deficient, hormone sensitive lipase activity goes up, it breaks lipids into free fatty acids and the free fatty acids enter the portal circulation, reach the liver and they act as substrates for gluconeogenesis. All this is going to cause hyperglycemia and we all know that it is going to increase the tonicity of the extracellular compartment, glucose. Water is going to get drawn from intracellular to extracellular and there is going to be osmotic diuresis. Patient is going to lose fluids. Patient is going to lose electrolytes. So this is the reason behind why patients are hydrated. They go into the AKI and they have dyselectrolemia in patients with DKA. Now the second most important point what all of you need to focus here is increase in the counter-regulatory hormones. Can you name some counter-regulatory hormones? Growth hormone, glucagon, cortisol, adrenaline, all these are counter-regulatory hormones of which I want you to remember glucagon. Glucagon plays a very important role in the pathogenesis behind this complication. So what happens is these counter-regulatory hormones, so normally what I told you because of lipolysis the fatty acids are reaching the liver but they are not able to enter the mitochondria. But this glucagon when it goes up in patients with DKA, it overexpresses something called as carnitine palmitol transferase. So once carnitine palmitol transferase is overexpressed, the free fatty acids cross the mitochondria, they enter the mitochondria where they undergo beta oxidation and beta oxidation of free fatty acids forms your ketone bodies. So what are the three ketone bodies? Primary ketone body is your acetoacetate, secondary ketone bodies are your 3-beta hydroxybutyrate and acetone. So this is the pathogenesis, absolute insulin deficiency and increase in counter-regulatory hormones. But what happens exactly in HHS is there is a relative insulin deficiency. But I expect you to question me here, sir, in absolute insulin deficiency the GRBS is 250, but why in relative insulin deficiency the GRBS goes to 600 plus? Anybody knows the answer for this? I told you that HHS the GRBS values are 2 to 3 times of DK, but HHS has only relative insulin deficiency, not absolute. Why? The reason being, classically HHS develops over a period of 1 week. DKA comes to you within 24 to 48 hours. That's why the blood sugar levels don't rise a lot. HHS develops over a 1 week and classical history which patients with HHS gives are, they are elderly patients with an underlying UTI who have not taken medications for over 7 days and they come up in a state of stupor or coma or cerebral edema. And when you check the GRBS, it is more than 600. So that is why despite them having a relative insulin deficiency, they have excessive increase in the level of glucose values. Now clinical features of DKA include all except the last limb. Clinical features of DKA include all except. Can DKA present as unrecognized acute abdomen? Yes or no? Fast. Kussmaul sign?
Yes.
Yes, okay. Stupor coma? Pulmonary edema. Can DKA have pulmonary edema? Okay. Weakness and fatigue? Yes. Okay, it's a very general question, right? Weakness and fatigue for all infections and all conditions. Kussmaul sign, sorry you lost your NEET exam. Kussmaul sign is seen in constructive pericarditis. What is seen in DKA is Kussmaul's breathing.
Kussmaul's breathing.
So what you need to see, what I want you to focus here is in all the 4 images, you have a y-axis and you have a x-axis. On the y-axis, you have something called as the depth of breaths, and on the x-axis, what we have represented is the rate or time. So all of us are eupneic because we have a normal rate and depth of breathing. Patients with tachypnea have increase in rate, but the depth of respiration is normal. Patients with hyperapnea have increase in depth, but the rate is normal. But patients with Kussmaul's breathing have a combination of tachypnea and hyperapnea. This is what is called as Kussmaul's breathing. And why the patient starts having hyperapnea and a combination of hyperapnea and tachypnea is, normally when we lose 1 millimole of bicarbonate from our body, the respiratory system tries to wash out 1.2 millimeters mercury of PCO2. But when in acute conditions like DKA, when there is an acute loss of 4 to 6 milliequivalents of bicarbonate, the body is not able to compensate and the patient starts having hyperapnea followed by Kussmaul's breathing, what was shown in the video. So these are all the clinical features of DKA. What I want you to remember is, most often patients with DKA present with unrecognized acute abdomen. Initially it was thought to be they have an underlying pancreatitis, but the most accepted theory is ketone body induced hypermotility of the gastrointestinal system and stimulation of the free nerve endings is the proposed pathology. Pulmonary edema, mainly because of Kussmaul's breathing, there is elevated pulmonary venous pressure, and due to the loss of proteins because of increased osmotic diuresis, there is increased capillary permeability. These two can put these patients to a risk of pulmonary edema. Fruity odor is very common. We have been learning from our UG times. It is mainly because of accumulation of ketone bodies. Now coming to the acute management of DKA. Now all of you know that the patients are extremely dehydrated. Correct? Agreed? Right. So fluids and fluids. This is the main treatment, and it has been found that these patients come with a loss of about 6 to 9 liters of fluid by the time they reach your hospital, and it is very important for you to resuscitate these patients. Right. Now apart from administering fluids, what is important is your glycemic control and also taking over the metabolic derangements. So you need to start them on insulin, and also you need to correct the metabolic correction, but do not forget your airway breathing and circulation. And always remember, DKA has an underlying precipitating cause. Find what the precipitating cause is and treat the precipitating cause. Now coming to fluid management in DKA, it is stressed that all patients should receive 1000 to 1500 ml, a liter to 1.5 liters of fluid in the first hour. Don't blindly administer fluid, always find out the cardiac status, renal status and the liver status. There are no randomized control trials which suggest appropriate rate of fluids. You can use the left ventricular outflow tract velocity time index, which is also called as the LVOT VTI, or the IVC collapsibility to check for the fluid status. You can do a point of care echo to look for the cardiac function before you administer fluids. Then followed by the initial bolus, start the fluids at 250 to 500 ml per hour. The American Diabetic Association and also the UK Council still go for 0.9% saline as the fluid of choice. And if the sodium levels are high, they ask you to replace it with half strength saline, which is nothing but 0.45% saline. Right. But these two important trials that came up in the emergency department, the SALTED and the SMART trials, compared isotonic saline with balanced salt solutions like plasmalite A and ringer lactate for patients coming with acute diabetic ketoacidosis. Now what they found was, what I want you to focus here is, the blue line is for the limb in whom balanced solutions were administered, and the orange is the one in whom 0.9% saline was administered. The potassium levels at the end of 72 hours of resuscitation, which we all are worried about, remained well below 4 milliequivalents per liter. Also, if you look at the bicarbonate levels were much better, and the time for the acidosis to resolve was much better in the patients who received plasmalite A and ringer lactate. Then why do we still stick to 0.9% saline? So in the availability of balanced salt solution like ringer lactate or plasmalite A, please choose them over 0.9% saline. Yes, of course, if the patient has an underlying hypernatremia, switch over to half strength saline. Now we have managed the fluids. Now next part is their glycemic control. When we talk about the glycemic control, obviously you have to start the patients on insulin. So you choose a regular insulin and you administer 0.1 units per kg bolus. and then you start them on an infusion of 0.1 units per kg per hour. Every hour your target GRBS should fall by 50 to 75 milligram per deciliter per hour. If the GRBS does not fall between 50 and 75 milligram per deciliter per hour, keep increasing your infusion dose gradually, and also most important is monitor your GRBS. If the GRBS falls below 200 milligram per deciliter, add 5% dextrose. Right. So most commonly what most of the articles recommend is a 2-bag technique. Whenever you have a patient with DKA, as soon as they enter, secure 2 wide bore IV cannulas, start them on 2 bags on either side of 500 ml of either ringer lactate or plasma lactate. On one side add potassium, because when you start insulin, potassium is going to go into the cells. So patients are going to have hypokalemia. So add 20 to 40 millimoles of potassium to one bag, and to the other bag you add dextrose only when the GRBS falls below 200 milligram per deciliter. Subcutaneous insulin can be given in patients who are alert, stable, but most important to note here is when you put these patients on subcutaneous insulin, if the anion gap does not close after 12 hours of starting subcutaneous insulin, please switch over to IV insulin. So what I want you to remember regarding potassium correction in DKA is there is a total body deficit of 300 to 600 milliequivalents in patients with DKA. Replace potassium only when the patient is passing urine. So most of these patients come with an underlying AKI and oliguria, give fluid boluses, kickstart their kidney, and then start administering potassium, because if you administer potassium without a urine output, the patients are going to have hyperkalemia. Metabolic correction. So this is a debatable topic. What I want you to remember is in DKA, the role of bicarbonate comes only when the pH is under 6.9, and remember, whenever you administer bicarbonate, there is going to be hypokalemia, so you have to be careful about it. So monitor GRBS every hourly, pH, bicarbonate and electrolytes every 2 hours whenever you are managing a patient with DKA. How do you know that the DKA has resolved? When the blood glucose falls under 200 milligrams per deciliter with any 2 of the following: bicarbonate above 15, or a pH of above 7.3, or an anion gap of under less than or equal to 12. Please remember this. So last slide. So this was a very atypical presentation of DKA. I was also quite surprised when I went through this case report. A 55-year-old lady has been posted for an elective procedure. All preoperative investigations including RBS is normal. She had a neurofibroma at the level of T10, T11. They gave a general anesthesia, and in the prone position the tumor was excised. She was extubated, shifted to the post-op. Half an hour into the post-op, they found her to have acidotic breathing. They did a GRBS. GRBS was 350. ABG showed a high anion gap metabolic acidosis, and she had DKA. Pre-op investigations normal, no history of diabetes. Retrospectively, they did a HbA1c. They found that the HbA1c was 7.3. So anesthetic surgical stress in the post-op can also trigger or a precipitating cause for an underlying patient with diabetes, which unmasking diabetes in the form of DKA. So monitor your patients. I think oration was very relevant. Vigilance is key to success. My take-home messages are: please find and treat the underlying cause. Fluid administration is the mainstay. Balanced salt solutions, yes, are of course replacing 0.9% saline. Blood ketones, if available, is very good. Otherwise, rely on urine ketones. Fixed rate insulin regimen is better than variable rate. Please have a high index of suspicion, especially patients who are coming to your OT who are on SGLT2 inhibitors. Skip these drugs at least 24 hours. Guidelines ask you to skip SGLT2 inhibitors 24 hours before an elective procedure. Optimize the patient until it's a life-threatening condition. These are my references. Thank you. Sir, I myself haven't seen any patient with SGLT2 inhibitors in my practice. We have had I think these two drugs are we need to be very careful. One is SGLT2 inhibitors, another one is GLP-1 analogs. GLP-1 analogs have been reported to cause delayed gastric emptying. So these have to be stopped at least 24 to 48 hours. There are a lot of case reports where patients with supraglottic airway devices have aspirated with GLP-1. And SGLT2 inhibitors, what the guidelines ask you to do is stop it 24 hours before. There have been case reports, but I myself have not encountered a patient who is on SGLT2 inhibitors.
We have had 2 cases with patients on SGLT2 inhibitors. They were stopped 3 days prior to surgery.
Right, sir.
Yeah, but they presented back with nausea, vomiting, euglycemia, ketoacidosis, and lethargy. So we had 2 cases.
That's what, sir. They have written at least 24 hours, if possible 3 to 5 days.
Yeah, in both these cases, we had stopped that medication for 3 days.
Yes, sir.
But still, we had euglycemic diabetic ketoacidosis.
Yes, sir. Thank you, sir.
Just a word of caution when you say fluids, fluids, and fluids. So in your previous slides, you said that they can present with pulmonary edema.
Yes, sir.
Right. So the thing is that there is a cause for which DKA has happened, and at times, if you think it is pulmonary, increased pulmonary capillary permeability, where you are probably having elements of ARDS, it's not wise to push fluids so fast in these patients. So though it's better to monitor the lungs, and it's better to look for the lung signs if they are appearing when you are monitoring, when you are transfusing fluids at that rate.
Yes, sir.
So it should not be blindly given.
Yes, sir.
They also have propensity for AKI, which you have rightly mentioned.
Yes, sir.
So if there is an element of AKI, again the lungs are the ones which will be affected.
Yes, sir.
Second thing is the most commonest mistake. The most commonest mistake which is done by most of us is that when you put them on ventilator or when you give general anesthesia to these patients, the ventilatory settings which are generally done are to 4 to 6 liters of minute ventilation. But remember, if you put them on that kind of control, their acidosis is going to worsen. Because if you look at the compensation, which I thought we should have mentioned clearly, that how much compensation is occurring by the kind of breathing or hyperventilation which they are performing, is to compensate for the acidosis. And when you compromise on that ventilation by setting your ventilators
at normal
respiratory rate, your acidosis is going to worsen. So you need to have the same kind of minute ventilation which the patient was having previously, which you should be setting on the ventilator to see that this is not compromised.
Yes.
Okay, just one more point I wanted to tell about pre-op evaluation. Many of the people started talking about some of the chronic kind of markers of diabetes. But what happens is when you're talking about diabetic ketoacidosis and all, you better look into more recent and which will tell you what is happening to the patient today and now, rather than yesterday and 3 months back. So don't think at that particular moment what is HbA1c, how does it matter whether it is a 8 or 6, whether you are going to really, if it is 6 means you might think it is not diabetes, but then don't go for the markers which are a long-term markers. You go for something which is acute. Same thing, somebody was also mentioning about urine ketones, all that. If possible, as he stressed a couple of times, it is a blood ketones, or at least go for the acid-base APG and then try to see whether there is a acidosis or not. Urine ketone, if it is an uncatheterized patient, you don't know when it was filtered after his full dinner, and then you will see it tomorrow morning, and that ketones will come in the afternoon, and finally you won't know what is. Sometimes you will see patients will have ketone positive and sugar plus. You do a random blood sugar with the finger prick method or something like that, sugar will be low. So what do? You treat that or you treat this. So don't go for the chronic markers for an acute condition. That's what I wanted to stress.
Yeah, good. Thank you. Congratulations to Dr. Eshwar.
Thank you, sir.
You reminded me my colleague for 15 years, right? And you deserve that. Took the award for Fanadinathwada Award.
Thank you.
Only difference is he used to move up and down there on the dais. You are moving among the audience. That's really reminder.
Thank you, sir. Thank you, sir.
See, the ketometers are available. They are just like your glucometers.
Yes,
and it's a very cheap equipment. The only thing is the sticks cost a little bit. I think they cost about 1200 or 1500 rupees one stick would cost. But you can readily do bedside the blood ketone bodies with just a prick. Both the sugar and ketones can be done.
Exactly, sir. So I think one important point, I do not know whether the audience has heard Pankaj sir or not. When a patient has a high anion gap metabolic acidosis and he comes with increased respiratory rate and the respiratory system is trying to compensate, and if it's an emergency procedure and you're planning for a general anesthesia, the minute ventilation should be equivalent to that respiratory rate. Do not keep it normal because it is going to increase your metabolic acidosis. So please keep this in mind.
Thank you, Dr. Eshwar, for ending the lectures of day 1 on a high note. I now request Dr. Malavika to join Dr. Eshwar on the stage.
Thank you, speakers. We will now have the quiz prelims. The quiz prelims will be hosted by our own faculty, Dr. Shreya Das Adhikari, Assistant Professor, and Dr. Savan Kumar Nagesh, Associate Professor. Over to you, sir and ma'am. Also reminding the delegates to kindly sign in for both the morning and the afternoon session.
We are going to begin the quiz prelims. I hope those who have registered are in the hall. I request all the participants to come forward, and those who are not participating to those who are not participating, I would request them to go towards the back of the hall, take the seats in the back. I request to sit in teams of 2, and please keep a seat in between, a gap in between. We have people who will be monitoring you, so no funny business. So if somebody wants to register, this is the QR code. Please register now, because we will not be able to allow you to participate in the finals if you do not register. I'll give you 5 minutes. Please register. Single phone in sight, please, for each team. Yes, only one person has to register. You register the team name, and anybody wants to participate, there's somebody who wants to partner up and participate. Anybody wants? Come on. It's a fun quiz. Just give it a go. Kona is already partnered up. Another partner required. For quiz only. Sarah wants to participate? Go ahead. Hey, don't force like this. All right, settle in. And also, please log into your Google accounts, because this will be on Google Forms. Everybody has a Google account, I hope. At least one person from each team should have a Google account. You need to log into your Google account and be ready, so that once the QR code is there, you will have just 30 minutes to complete your prelims. Okay. How many are yet to register? Hands up, please. All right, I'll give you one more minute. So, we have single best response. Can we switch to my slide? Yeah. Single best response for multiple choice question. 1 mark for each correct answer. There are no negative markings, so I request everybody to answer all the answers. Top 5 teams will qualify, and we have 3 winners at the end. The finals are tomorrow in the evening, about this time. All right, go ahead, complete your registration. So for the finale, we will only permit 2 teams per college or hospital, to be fair. In case of a tight score in the prelims, the team that submits earliest will be selected. We get the timestamps from the Google form, so it's very accurate, 2 milliseconds, so don't worry. We'll be flashing the QR code now. Your timer for 30 minutes. I'll tell you when to start, okay? Timer for 30 minutes will be started. 25 questions, 30 minutes, no cheating. Don't Google, we'll be going around seeing your phones. Okay? All set? Scan your, I'll give you 30 seconds to 1 minute to scan, then I'll start the timer. 1 minute, start the time, I'll let you know.